Pyelonephritis is inflammation of the renal tissue. It usually begins with a UTI that travels to the renal tissue. It presents with the same symptoms as a UTI, including fever, malaise, and flank pain, plus more severe symptoms like nausea, vomiting, and costovertebral angle tenderness. This can be acute or chronic, and if it's chronic, you may see renal scarring and altered kidney function. Pyelonephritis is diagnosed with a UA, culture and sensitivity, white blood cell count, or ultrasounds, and it's treated with antibiotics, fluids, and urinary analgesics, just like we would a UTI. If this patient reported tenderness upon assessment, would you document this as left or right-sided CVA tenderness? Looking at this picture, this would be left-sided CVA tenderness. Urethritis is inflammation of the urethra. This is common with STDs. Examples are gonorrhea, chlamydia, syphilis, etc. So for these patients, it's very important to get a social history upon admit. Urethritis presents with the same symptoms as a UTI, so things like dysuria, urgency, and frequency. And we're going to treat this with antibiotics. Don't confuse this with pyelonephritis. It does seem very similar, and history is very important with both of these. With pyelonephritis, you want to ask the patient about a history of UTIs. With urethritis, you're looking for a history of STDs. Interstitial cystitis, also known as painful bladder syndrome, is chronic painful inflammation of the bladder. It presents with the same symptoms as a UTI, so things like urgency, frequency, and dysuria. The cause is unknown, however. So because the cause is unknown, there's no treatment. We call this a rule-out disease. So what we do is we rule out it being a UTI or any other possibilities. And once all of that is ruled out, we diagnose the patient with interstitial cystitis. So your patient has symptoms, but no cause for the symptoms. Also, all of their diagnostic testing, vital signs, lab values would all be normal. So with these patients, we do want to do some symptom management. So we'll have them avoid irritating foods and beverages, and there is an over-the-counter medicine that they can take called Preleaf, which alkalizes the urine and kind of helps to manage some of those symptoms. And we teach them to take that prior to consuming any irritating foods or beverages. A urinary obstruction is anything that blocks urine flow, and this is commonly from stones or inflammation. Complications of this can be urine reflux, which could lead to hydronephrosis, and hydronephrosis can lead to renal failure. On the picture on this slide, you can see that the urine is backing up because of an obstruction, and that urine is staying inside of the kidney. And as we retain more urine, we start putting more pressure on the renal tissue, and that can cause the damage. Urinary tract calculi. Calculi is another name for a stone. With this, the patient presents with very sharp, severe pain and nausea and vomiting. We diagnose this with a CT or an ultrasound, and once we know that there's a stone, we'll have our patient strain their urine. That way we can catch any stones that they passed and send it off to the lab for further testing. Hopefully we can figure out what the stone is formed from. That way we can edit our patient's diet and hopefully prevent more stones from forming. Risk factors for developing these stones are their diet, a history of UTIs, or dehydration. To treat stones, we want to increase fluids. We want to control their pain with pain medications. Give them antiemetics for the nausea and vomiting, so things like Zofran or Phenergan. We can give them tamsulosin to relax the ureters to help the stone pass on its own. For certain types of stones, we can use potassium citrate to alkalize the urine. And then we can also do surgical intervention if the stone can't pass on its own. For the surgical intervention, we'll call the procedure a lithotripsy. And that's when they go in and break up the stone so the stone sediment can pass out of your patient's urinary tract. There's different types of lithotripsies that can be done, but they're all used to break up and eliminate the stone. This can be used with scopes and saline washouts as well. They may put in a urethral stent either temporarily or permanently to help open up those passageways for the stone or any future stones to pass. After the procedure, we always want to encourage fluid intake, so increase the fluids to help pass the stone and all of the sediment. And also have your patient strain their urine so we can capture any stones that are passing. The individual treatment of the stone is going to depend on the type of stone. But what we want to make sure we remember is for all stone types, whatever type of stone your patient has, we want to increase fluid to help pass the stone or any sediment after a lithotripsy. A ureteral stricture is the narrowing of the ureter. This is from scarring, usually from a surgery, and we treat this with a stent or a urinary diversion, so like a urostomy. With this, it's going to be above the level of the bladder. So your ureter connects your kidney to your bladder, and at some point in this ureter, we would see some narrowing. And because of that, the urine won't be able to pass through the ureter to get down into the bladder. So we'll see a urinary obstruction and a decreased urinary output. With a urethral stricture, the narrowing is going to happen in the urethra. So this is below the level of the bladder. We typically see this from inflammation, and we treat this with either a stent or a catheter. So this will also affect urinary output. It's just the location of where it's happening. So for this one, the urine has already made it to the bladder, but it can't get out of the bladder. For the ureteral strictures, the urine couldn't get into the bladder.